Bismillahirrahmanirrahim. In the name of Allah, we begin with His help we learn and by His guidance we succeed. I am Dr. Sadia Nas, consultant obstetrician gynecologist, and today I'm here to discuss a very high topic for FCPS, MS, MRCOG, and IMM. That is the management of term breech presentation. It is evidence based. You can say that, as you know, that there are very recent updates and books are very much outdated right now. So we are going to discuss these latest evidence-based guidelines regarding the management of term breech presentation. So when you talk about breech presentation, there's a concept that most term breech babies are delivered by cesarean section, but a small numbers are born vaginally. So what is important? Important is counseling and skilled operators for vaginal breech birth. It is essential if you're offering a patient vaginal breech birth, it is important that the operator must be skilled. Also, external cephalic version, which is safe, acceptable to most women, but has few contraindications. And if it is successful, it increases the vaginal birth rate. Also, routine third trimester ultrasound can prevent most undiagnosed term breech presentation. And more research is needed regarding vaginal birth simulation training and clinical practice. Nowadays, obstetricians are not that much trained in vaginal breech practice. Whenever a patient comes to them that the patient is breech, they are most likely that go for cesarean section. Why? If there are no contraindication, go for it. So after this lecture, you should be able to understand the evidence behind the term breech presentation. Discuss external cephalic version, vaginal breech birth, cesarean section, and what are the adjunctive methods. You should know the prerequisites and contraindication for vaginal breech birth and understand the principles of physiological breech birth. So let's get started. When we talk about breech presentation, it is a longitudinal fetal lie in which the buttocks, feet, or knees they present first instead of the fetal head at the pelvic inlet. In short, उर्दू में बताएं, buttocks पहले आएंगे, head नहीं आएगा, या feet हो गए या knees होंगी. And it occurs in 3 to 5% of single-term pregnancies at term. अगर 28 weeks की बात करें, then the incidence is 25%. But it spontaneously revert to cephalic presentation in 3 to 5% single-term pregnancies at term, and majority convert to cephalic before term. Okay, so most fetuses are cephalic by delivery. So it means that if a patient comes to you at 28 weeks and you tell them that it is breech, the patients panic. They say that that doctor told us that the baby is breech. So is this baby going to be delivered a cesarean section? No, you cannot judge it at 28 weeks. We will have a repeat ultrasound at third trimester. We will see, because mostly there is spontaneous version. They go into cephalic presentation by term. So there are certain types of breech. Forget the images. I didn't get very good images at all. So first is frank or extended breech. Most common, 2/3 of the cases in which the hips are flexed and knees are extended. In this picture, this is wrong. The knees are extended and touches the fetal head. Okay? So it accounts for approximately 2/3 of all breech presentation and most suitable type of vaginal breech birth if other selection criteria are fulfilled. Usually in primaries, these type of breeches are present. Then complete a flexed breech. Hips are flexed, knees are flexed, and appearance is cross-legged. Third is incomplete or semi-flexed, in which one or both hips are flexed, or one or both knees are partially flexed. This is incomplete flex, is semi-flexed or incomplete breech. Then comes a foot-leg breech, in which either one or both feet come down through the vagina, and there is high risk of cord prolapse. It is a contraindication to prime vaginal breech. It's like आप suicide कर रहे हैं भाई, बच्चे को मारने वाली बात है. Then kneeling breech, which is rare, in which knees present forward and is usually liver cesarean section, so बच्चे के stuck होने के chances ज़्यादा हैं. So now, what are the risk factors for breech presentation? There are multiple factors. In different books, different factors, but in maternal factors, nulliparity. If the congenital glandular abnormality, ठीक है, fibroid, multifibroid uterus, or if the patient is obese or there's raised maternal BM. Fetal factors include if there's oligohydramnios or polyhydramnios or small for gestation age. But you should know it very clear that if a patient comes to you with footling breech or kneeling breech, they have high risk of cord prolapse and they're not suitable for planned vaginal breech, but it should be clear in your mind. They are not suitable. This is a very important pearl. All right. Am I clear so far? Now, how are you going to manage? There are three management options. A woman with term breech fetus should be offered three options. You will offer three things. First line is external cephalic version. It is first line. Then planned vaginal birth. It is planned cesarean section, second. And planned vaginal breech birth. Only in carefully selected women with experienced team, third thing. Individualized counseling is essential to enable informed consent. If we are saying that we are giving the options of PCV and we are giving the options of planned cesarean section, we are giving the option of planned vaginal breech birth, and this should be in your mind that there are certain prerequisites that you have to follow. It is not like that there is a patient previous to scar and you were doing ECV, है ना? If it's abruption, you're doing ECV, right? Or if there is previous to cesarean section with breech, you are going to do her planned vaginal breech. But no, there are certain prerequisites that you have to follow. Now, what is term breech trial? It is very important for the talks as well. This can be asked in your vivas, and it is very important in theory. It was a study which was published in Lancet 2000, and it randomized almost 2,000 women from 26 different countries and compared basically planned cesarean section versus planned vaginal breech birth. So the main finding was that when cesarean section was performed, there was lower perinatal neonatal mortality and serious neonatal morbidity with planned cesarean section. It was low, but there was no significant difference in serious maternal morbidity or mortality. Cesarean section is safe for baby in breech baby, but there's no significant difference in maternal morbidity or mortality in both cases. It significantly influences the clinical practice and increases the rate for planned cesarean section for breech presentation at term. Now, what was the criticism? There were poor adherence to inclusion criteria. They overrepresented macrosomic babies like more than 4 kg. And there was significant variation in standard of care between centers. Some centers provide more care, more one-to-one guide, more one-to-one monitoring, more hands-off technique. And these were the significant variation. And many vaginal breech births were conducted by inexperienced obstetrician. It is very important. If an obstetrician is conducting vaginal breech birth, make sure that she or he must be experienced. Then several neonatal deaths were unrelated to the mode of birth. It was not related whether it was breech, vaginal breech, or cesarean section. And definition of neonatal morbidity was questions because many people were recovered completely after 1 year. So these limitations suggest that the result of term breech trial may not fully be generalizable to settings with strict selection criteria and experience needs. In our clinical practice as well, when I do also breech delivery, so I see when a patient comes in labor and she is in active labor and we deliver her, so if you are experienced enough, you perform it, right? इससे अच्छा क्या होगा कि पेशेंट आपका जो है वो स्कार से बच जाए. The evidence after the term breech trial, there was performed a pre-moda study in 2006 in which it was a prospective study of more than 8,000 women. It was conducted in France and Belgium and showed no significant increase in perinatal mortality. When the women were carefully selected, labor was managed using strict protocol, and experienced obstetrician conducted vaginal breech birth. Current evidence support offering planned vaginal breech birth only in appropriately selected women and centers with experienced clinicians. Now, what is external cephalic version? I love it. I love external cephalic version. I don't know how many of you have performed, but please, if a multi comes to you and she allows you, she gives you consent, do perform it. It is a first line management for term breech presentation. Patient cesarean section se bach jati hai. It is a procedure in which the fetus is turned from breech to cephalic presentation by external manipulation of the maternal abdomen. As you can see in this picture, that it is doing external manipulation, either like this or like this, right? But patient जो है वो cesarean section से बच जाती है अगर ये आपका successful हो जाए. So it increases likelihood of vaginal birth. Approximately 50% success rate in term breech pregnancy, 60% ये multiparous में होती है और 40% ये प्राइमरी पैरा में सक्सेसफुल होती है. प्राइमरी पैरा में इसलिए थोड़ी सी रिजिड एब्डोमेन होता है तो उसमें थोड़ी सी मुश्किल होती है, बट मल्टी पैरास इट इज वेरी इजीली एंड ब्यूटीफुली डन. It is safe and cost effective and offer ECV to eligible women with term breech to improve the chances of vaginal birth and reduce unnecessary cesareans. Now, what are the factors that increase the success rate? First of all, provider must be experienced. Multi-parity, increasing maternal age, non-engaged breech, pre-procedure tocopherol with ethyl nifedipine, salbutamol, low maternal BMI, if the placenta is posterior, if the breech is flexed or complete, and if the AFI is normal. But if the woman is nulliparous, she is obese, franco-extended breech or footling breech, there are less chances of success. So, in a woman who comes with breech presentation, you have to do ECV. Then offer ECV from 36 weeks in primary gravida and from 37 weeks in multi-gravida, provided there are no contraindications. This is very important. Now you have to, what is the safety point? That serious and maternal and fetal complications are rare, but pre and post procedures is recommended. And if the patient is having negative blood group, then administer anti-immunoglobulin within 72 hours if the mother is rhesus negative, unless the fetus is confirmed RH negative. After successful ECV, continue your routine antenatal care. Okay? And cesarean section within the next 24 hours is very uncommon, like less than 0.5%. How it is performed? First of all, you will take informed consent. You will tell the whole procedure. Take informed consent. Then you will ask the patient to lie in supine position. Perform by external manipulation of the maternal abdomen. Usually done under ultrasound guided supervision. Pre and post procedure CTG is recommended. Routine IV access is not necessary. But if during ECVs there's transient bradycardia lasts less than 3 minutes, continue the monitoring if the bradycardia persists, deliver in less than 12 minutes. Very important. Attempts within a 10 minutes should be the upper limit. If it is failed, you can attempt after 10 minutes, but upper limit is just 10 minutes. If unsuccessful, later attempts will be performed by a more experienced operator. आपसे नहीं हो रहा, आप अपने से किसी सीनियर को या फिर एक्सपीरियंस ऑपरेटर से कहें कि वो करे. पेशेंट्स के साथ नहीं खेलना, वो पेशेंट है, आपने किसी एक्सपीरियंस बंदे से कराना है, because there is a risk of bleeding, there is risk of abruption. You have to know that. So perform with ultrasound supervision, keep the attempt time within 10 minutes and safety is enhanced by continuous monitoring. After ECV, continue routine low-risk antenatal care if there are no absolute obstetric indications. Cesarean section within 24 hours is uncommon. And also administer NTD immunoglobulin within 72 hours and consider Clearhot test to identify women needing additional NTD. अगर आपको लग रहा है कि fetal maternal hemorrhage हो गया है, तो go for Clearhot test. Now, what are the alternatives? There are certain alternatives, but the evidence is limited, like moxibustion. They use Chinese herbs in maternal abdomen and it encourages the spontaneous burden, but the evidence is very, very limited. Anti-CVD performs RCVD supports the use before 33 weeks. Posture management, like all foot position, knee chest position, or hip elevation. And Muslims, we tell in namaz, make namaz type position, sajda position, right? These techniques are commonly tried, but current evidence does not support their routine use. But ECV remains the first line approach for term breech presentation. When is cesarean section recommended? Most term breech pregnancies are delivered by cesarean section. Either it is performed as maternal choice or when there is external cephalic version. But confirm breech presentation by ultrasound immediately before surgery. Around 8% of breech fetuses spontaneously turn cephalic before delivery, and this is important exam point. Important exam point. During cesarean breech delivery, it may require Lofset maneuver or Morris's Malevite maneuver for difficult extraction. Avoid hyperextension of the fetal neck. It is a safety point and deliver gently with controlled traction to minimize fetal injury. Always confirm fetal presentation by ultrasound before performing a planned cesarean section for breech presentation. Now, vaginal breech birth. It is a safe option for selected women when conducted by skilled hand. But it can be offer unbiased counseling. You have to tell the contraindications, you have to tell the pros and cons to the patient. You have to help the patient decide between ECV, planned vaginal birth, cesarean section. You cannot impose your own points to her. You have to tell every point, and then you have to take informed choice consent. It should be offered to only to carefully selected women. It must be conducted by experienced obstetrician. I'm repeating again and again. The obstetrician must be experienced, and if vaginal breech birth expertise is not available, go for cesarean section. Don't try on patient. They are not mannequins. So requirements are appropriate case selection, experience birth attendant, continuous intrapartum assessment, immediate access to emergency cesarean section if available. Now, what is physiological breech birth? It is a physiological approach to vaginal breech birth. It is a modern approach that aims to optimize and restore the normal physiological birth process. Interventions are performed only when clinical indicated. Perform usually hands-off technique. कुछ भी नहीं करना. जब buttocks निकल के आएंगे तो आप wrap करेंगे. You will wrap the warm moist towel around the buttocks and you will deliver the baby. Encourage the upright maternal position which are associated with reduced risk for labor, less neonatal birth injury, shorter second state of labor, maintains sacro-anterior fetal positioning throughout the labor, allows spontaneous fetal descent and rotation with minimal unnecessary intervention. So, encourage upright maternal position, which are associated with reduced need for maneuvers, less neonatal birth injury, shorter second state of labor, maintain sacroanterior fetal position throughout labor, and allows spontaneous fetal descent and rotation with minimal unnecessary intervention. It is basically hands-off technique when normal, hands-on only when indicated. Don't touch the patient. Hands-on when indicated. Allowed spontaneously to deliver. Can undiagnosed term be prevented? Yes. Provide appropriate antenatal counseling. Ensure the women understand all available management options. You have with child patients that, madam, there we have three available options: ECV, planned cesarean section, planned vaginal breech birth. Ensure the woman understands and enable informed decision making before labor. And also, there is evidence that routine third trimester ultrasound screening around 36 weeks of gestation significantly reduces undiagnosed breech presentation at term. This will help you that the patient does not sue you. If she comes to you and she says that I was throughout the pregnancy, now it has gone breech. So routine third trimester ultrasound screening around 36 weeks of gestation significantly reduces undiagnosed breech presentation at term. So universal ultrasound screening at 36 weeks mark reduced undiagnosed breech presentation, increase the opportunity for ECV in planned mode of birth, and associated with reduction unexpected vaginal breech birth. Now let's do some brainstorming. A 37-year-old primary gravida, frank breech presentation, confirmed on ultrasound, pregnancy is otherwise uncomplicated. She wishes to avoid cesarean section. Appropriate initial management? Yes, ECV. Why? Because for an uncomplicated term breech pregnancy, the first line management is to offer ECV to increase the chance of a cephalic vaginal breech birth and avoid cesarean section. So counsel, attempt ECV, plan mode of birth. You know, in my clinical practice, I have done ECV and I just love it. The satisfaction that comes on patients' face when they say that Allah ka shukar, हमारी normal delivery हो गई और safe हो गया और हमारा बच्चा सीधा हो गया. So it's very satisfying for you. According to current evidence, the first line management for an uncomplicated term breech pregnancy is external cephalic version. Other options are planned cesarean section, no. Immediate induction, no. External cephalic version, yes. Internal podalic version, no. It is done for delivery of the second breech twin. For uncomplicated term breech pregnancy, recommended first line ECV. Now, which breech presentation carries a high risk of cord prolapse? आंखें बंद करके, foot-link breech. No, frank breech is common. Complete breech, no. Flex breech, no. Extended breech, no. Which type of breech presentation is most suitable for planned vaginal breech birth? Frank breech, in which hips are flexed, knees are extended. Which factor is associated with highest chance of successful ECV? Multiparity. Most strong risk factor. Others are adequate amniotic fluid, unengaged breech, posterior placenta, normal uterine tone, and experienced operator. A woman undergoes successful ECV 37 weeks. What is the next best step? What is the next best step? Routine antenatal care. Ask the patient to come after 1 week. The term breech trial concluded that vaginal breech infection, no. ECP should never be offered, no. Planned C-section reduce serious neonatal morbidity and mortality, yes. Maternal mortality was higher with the infection, no. There was no significant difference. This study supported carefully selected vaginal breech birth and experience and a pre-moda study in 2006. In 2016. Which statement best describes physiological breech birth? Intervene only when clinically indicated while allowing physiological but hands-off technique. It was a past record. A 29-year-old primary evidence seen at 37 plus 2 week gestation. Ultrasound confirms a frank breech. Baby, but she asked whether the baby is still likely to return to cephalic presentation. So the answer was that around 8% of breech fetuses will turn spontaneously after 37 weeks. This is exam-oriented point. Okay. Now, if a patient comes to you, term primary gravida, she has got plan vaginal breech for 39 weeks, delivery is uncomplicated, and baby cries immediately. During neonatal examination, the left upper limb appears limb, shoulders adducted and internally rotated, but the elbow is extended. The rest reflex is intact, but morose reflex absent. What is the most diagnosis? Abstitution palsy, C5, C6. So I hope that you have learned something about breech presentation. Thank you for learning with me. And if you found this session helpful, so you can like, share, and subscribe. And again, I have started this labor series. I'm going to upload further videos for you. For it will be Sadka Jariya for others as well too. That will help to clear the exam. Thank you so much.